So Dr. Jason Williams
Yes.
from the Williams Cancer Institute. So Dr. Williams is a medical doctor, board-certified radiologist, image-guided cancer specialist, researcher, and professor. He's one of the pioneers in immunotherapy, specializing in intratumoral interventions. He performed the world's first ablation procedure and implemented an intratumoral injection of a specific combination of immunotherapy agents, thus leveraging the actual process of ablation as an immunotherapy agent itself. Since then, he has performed thousands of procedures, many of them first in human, in multiple areas of ablation and cryoablation therapies. Please welcome Dr. Williams.
Thank you. Appreciate that. Thank you. Thank you for having me here. Appreciate everybody. Appreciate James Stroll and everybody getting this event together. It's good to see everybody. Of course, obviously we're all here really with one main goal. We want to live a really long time. We want to live and be healthy. And the one thing I would say is that if we're going to achieve this, we have to be able to cure cancer, because if we can't cure cancer, we're not going to live very long. And we're seeing incidence of cancer going up more and more. They just actually put out something saying that the incidence of cancer in people from 40 to 49 years old was up 79%. So it's a very important area, and there's a lot to be learned as far as related to anti-aging as well. Understanding cancer leads to a lot of being able to help people keep from aging, which I'll explain in several, and also have a talk later today, which I'll discuss. And my big area of work is where we inject things into tumors, or we go right into tumors with needles. This is not, science fiction. This is what we do all the time. We can stick needles in tumors anywhere in the body, just like you do a biopsy. And you can stick a needle in a tumor. You can use something to destroy part of it. You can freeze it. You can send an energy into it and destroy it. And then you can inject medications into it and cause the immune system to attack it. I wrote this book. This book was mainly because, of course, now with cancer and everything's going towards immunotherapy. Everybody, they want to get away from chemotherapies. Obviously, we know chemotherapies are toxic and difficult, and you want to get your own immune system to attack the cancer. So now in cancer treatment, 60% of patients are receiving immunotherapies of some form during their treatment. So things are changing. Eventually, we're going to be able to get mostly away from chemotherapies and other, treatments, and move towards, getting your own immune system to attack the cancer. And a lot of times, people are like, well, I live a healthy life. I eat well, I exercise, I do all these things, and yep, that's most of my patients as well. And so, it's not. None of us are immune to cancer. All of us know. I think all of us know that this is the fear that you have. Every time something, did I feel something? Cough. Those things, could it be cancer? So we need to be able to treat this in a way where we don't have fear. And so in my book, I describe a lot of using off-label medications. There's a lot of drugs that exist already that can help cancer patients. Of course, supplements, plenty, supplements. I don't know if Bill's around, any Bill Falloon, but Life Extension, I buy plenty of their stuff, and we recommend plenty for our patients. And then also, for this, the patients that are getting immunotherapy is very fickle. There's a lot of things that you can do that will mess it up. And so patients don't know this. There was a study that came out a year and a half ago that showed that if you give patients acetaminophen, Tylenol, that immunotherapy will not work at all. That was shocking. Obviously, if you look, Tylenol is a pre-medication for lots of cancer treatments. I never was a fan of it. Obviously, it's hard on your liver. It's not really a great medication overall, but it's used a lot, and unfortunately, it's messing people up. And so there's a lot of issues there. And so This book was designed to help guide the patients so the patients who are getting immunotherapy can try to take take action, take charge of their own care, and to improve their response. I tell people, if you're a cancer patient, it's like being either a world-class athlete or an excellent student. If you're going to be a world-class athlete, you don't expect to just show up to practice, to go to practice, and then be a world-class athlete. No, it's going to take lots of dedication. You're going to have to try to do everything you can to get an advantage. And that's the same thing for the cancer patients. They can't just expect to just show up to their doctor, whatever their doctor tells them to do that, and that's going to be the best. They've got to take into their own hands and try to enhance their care. They've got to be like that world-class athlete. Get every advantage that you can to get success. So, as I mentioned, ablation, not sure, a lot of people may not know what this is, but this is actually a pretty common technique, becoming more and more common, where we stick a needle into a tumor and we destroy it by various methods. Now, there's lots of different types, but I'm going to explain kind of the two where things are really going. One, of course, is cryoablation, which is freezing. So you stick a needle in a tumor and you freeze it. Sounds very simple. You think, oh, well, that should be obvious, and it is, but it will kill tumor, and then it'll leave the pieces where the immune system can see it. And so then the immune system sees that and can potentially attack it. Just like the concept of a vaccine where you have like a killed virus. But, cryoablation obviously is not perfect. There's a lot of factors that are involved in it. There's other technology that we're looking at now, like pulsed electrical field, where we put a needle into a tumor. We send an electrical discharge. That discharge causes the tumor to die by opening pores in the membrane that results in apoptosis, and that attracts the immune system. And that causes the immune system to see the cancer. And this is a technique, that we do a procedure, and then we can inject medications with it to boost that. So you're killing tumor, but now you're injecting stuff into that tumor to cause the immune system to attack it. And a lot of times the oncologists are like, well, that's great, but you treated that one tumor, but what about the others? This is not just about the tumor that you're treating. This is a global treatment. You teach the immune system in one spot, it knows in the other areas, and it will go and attack it. This is what we call the abscopal effect. And so that's the beauty of this, is that this is not just a local treatment. As one of my colleagues came up with the term, he said, treat locally, act globally. And that's what we see with ablation. And, again, now with imaging technology, we're able to access most tumors. This is not something that's, only for a few patients. Many, many patients would qualify. The other thing is that, earlier in cancer, patients would get diagnosed, you could treat, you could stick a needle in a tumor, you freeze it, you do pulse electrical field, you inject immunotherapy, and you treat it. We do cases where we see a tumor, we don't know it's cancer, we biopsy it, we then ablate it, and then we inject it. The pathologist tells us it's cancer, and the patient comes out and says, well, you're diagnosed with cancer, we treated it, and now you're good. So, and that's where things are going. So you can see on this just kind of talks a little bit about with cryoablation, where you're freezing tumor and you're getting immune stimulation, you're killing tumor cells. The immune system is recognizing and seeing those. There's a lot of things that are going on, but ultimately you are doing this where the immune system can see the cancer and attack it. Now, it's not perfect. Cancer is very sneaky. Cancer really is part of your own body. It is behaving like an organ. So, it takes a little more than just killing tumor. One of the things that was interesting in studies, and this just proves the fact that there is an immune response. When you look at this, they did surgery, and they challenged these animals with tumor, and you can see surgery, cryoablation alone drops off. If you look at cryoablation with a drug called cyclophosphamide. Now, cyclophosphamide is a chemotherapy, but it's a chemotherapy that it normally suppresses the immune system, but the immune system sometimes is working for you and sometimes is working against you. A lot of people say, well, I got cancer because my immune system was weak. Well, that's not always the case. The immune system is trying to attack foreign things, but it's also trying to protect you from attacking yourself. And so cancer exploits that mechanism and will get the immune cells working for it. So when you use the drug cyclophosphamide with the freezing, so you're killing some of the immune cells that are protecting the cancer, then you see a significant improvement in survival. Then you can actually take these animals, you can freeze their tumor, you can inject cyclophosphamide, then you can wait 40 days, you can inject them again with cancer, and as you can see, almost 80% of them are immune. So it's definitely demonstrates that this technique can create an immune response and lead to cures in cancer, which we know and we've demonstrated. Then we get a little more sophisticated. We look at things like CpG, which I'll explain. CpG is a single strand of DNA that's found mostly in bacteria. So it's something that your body recognizes as foreign. So when it sees it, it's a danger signal. It's like, oh, I need to attack it. And so when you do this cryoablation, you freeze part of a tumor and you inject CpG, you can see in the animal model, top line, 100% cure. 100% cure. Well, now, obviously, we cure mice all the time. I mean, mice are easy to cure. They're clones, they're the same. Humans are completely different. But clearly, if that works in mice like that, then that's something in humans as well. And of course, we've done that work. Of course, you can see here where we look at mixing various things like vaccine adjuvants. So, if you take a vaccine like a virus, and you can't just kill a virus and inject it in a person and expect that they're going to generate immunity. Sometimes you have to put things with it to help the immune system to see it. And so we do the same type of thing with this. We would freeze a tumor and we would inject these agents that are used with vaccines to enhance the presentation to the immune system. And you can see, of course, it results in improved immune response against a cancer. So, a lot of people are like, well, I don't really hear too much about this. Is this really real? Well, here is a study, Sloan Kettering. You can see one of the authors, James Allison, he won the Nobel Prize in 2018 for his discovery in immunotherapy. He's also shown that if you take these drugs and you inject them into tumors, they work better than if you give them intravenously. So it's significantly better. It's actually almost 3 times better. So, and even with a single treatment injected into the tumor can be better than lifelong intravenous treatment. Now, that's really good. The drug companies don't like that too much because that really cuts into their dosing, but it's definitely much more effective. And the thing is that the tumor, you need to get the drugs to the tumor. When you get the drugs into the tumor, the immune system can see it and can attack it. So cancer itself, it's like Star Wars, like the Death Star. The Death Star had this force field around it, and you couldn't attack it unless you shut down that force field. So what we're doing is we're injecting into the tumor, so we're putting that bomb right into that hole, just like they did in the Death Star, and helping blow part up of the force field, and now the immune system sees it. And so that's how this really works and allows us to see and be able to attack and kill cancer. Very effective technique. This is clearly the direction that we have to go with cancer treatments. You need to be able to use lots of different drugs, but you can't give a patient 10, 15, 20 drugs systemically, but you can inject those into a tumor. Small amounts into the tumor will then change that area in the microenvironment of the tumor, will allow the immune system to see the cancer, and the immune system will then attack it in other places. So we've worked on sort of a complex combination, because obviously when you're dealing in human patients, much more difficult than in animals. You have many different things going on. And you look at like the DNA of the tumor. A lot of times patients will say, well, I don't have any genetic history of cancer. No, but your tumor DNA is different than your DNA. The tumor, it has to be, otherwise it would be you. So what happens, it gets mutations, it's different. So those mutations do certain things. Depending on the mutations that you have, you can then look at that cancer and say, oh, this cancer is going to behave this way, this cancer is going to behave that way, and you know sort of how to target it. And then we look at things like the gut microbiome, the bacteria in your intestines. The majority of your immune system is actually along the lining of your intestines. And the bacteria in your intestines are metabolizing food. They're sending chemical signals to your immune system, either turning it on, turning it off, making it better or worse. And there's ways that we can manipulate that to help improve the immune response against cancer. Of course, and I'll talk about this this afternoon, how the microbiome is probably a huge factor of why we're seeing more cancer. We have such an insult on our microbiome, so much antibacterial, antibiotics, lots of processed foods, artificial sweeteners. I mean, if you look at things like sucralose, and sucralose structurally is similar to an antibiotic, and it actually kills bacteria in your intestines and reduces your flora. Then, well, a lot of times patients say, well, I don't use sucralose, I'm stevia, I'm natural. Stevia does as well. Stevia actually also functions like an antibiotic and will kill bacteria just as bad as sucralose. So it's not just because it's natural doesn't make it good, because there's lots of natural things that'll kill you. So it's very, very important to know that these things are messing up our microbiome. A lot of the foods that we eat are leaving us with less diverse bacteria. Our immune system is then weakened, and we're not able to fight. So this is one of the big things that we're looking at. It's a huge area of interest for me, is the gut microbiome. But we look at this whole interplay, and we've actually even developed like an artificial intelligence. Obviously, everybody wants to do AI nowadays, and so we've got a system where it looks at all the different factors going on with the patient, the DNA in the tumor, the patient's DNA, the RNA, the protein expressions, the receptors on the cancer, all these different things. And it comes up with sort of a plan, and it's not even limited just to like typical drugs, but includes supplements like curcumin and vitamin E and D and things like that, and then off-label drugs that you can use. So there's a lot of drugs that are out there. I mean, really, the cure to cancer exists. It's there. The drugs are there. We don't need to make new discoveries. We have everything we need. We just need to put it all together and make it work. And that's the part that's been challenging. So when you look at cancer immunotherapy, so a lot of people don't, unless you're in cancer, you don't really know, but what's the difference between cancer immunotherapy versus chemotherapy? Immunotherapy obviously is focusing on hitting certain receptors, trying to get your immune system to see the cancer. Chemotherapy are generally drugs that are toxic to your DNA, toxic to certain proteins, so that you're trying to kill cells, but it's fairly indiscriminate. With immunotherapy, there are certain things where the cancer is engaging receptors and saying, hey, I'm part of your own body, don't attack me. And so you block those. You try to block those signals, so we use drugs to do that. Now, think about this. This is what makes really good sense. You don't want to block those signals everywhere in your body. You don't necessarily have cancer all over in your body. You want to block those signals where the cancer is at, so that the immune system will then see it and change. As a matter of fact, if you give these drugs throughout your whole body, and now they're binding everywhere where you don't have cancer, the immune system gets confused and thinks, oh, well, gosh, I'm supposed to attack everything, and then it shuts down. And so that's why going into the tumor is very effective. But there's ways where you're blocking certain receptors that the cancer is using to shut off the immune response. You're activating certain receptors to turn on the immune response. So lots and lots of interplay. There's so many drugs that are involved in cancer immunotherapy. I mean, we regularly are using 8 to 14 drugs in patients. There's hundreds that are available. And so with those right combinations, you can achieve great responses. So, again, we're not the only groups that have shown this. Others have shown that you can inject immunotherapy into tumors, into a tumor, and you can get a global response, a cure. And that's what the group at Stanford showed when they were doing their study, looking at a combination of immunotherapy with OX40 and CPG. This is one of our cases. So the image to the right, you can see, we don't have a pointer, but I think, well, I don't know if this shows here. No, there's a needle sticking into a tumor that actually is right behind the heart. It's a tight spot. I stuck the needle in there. I froze the tumor that was in a lymph node. And this patient who had a big lung cancer that you can see over on the left side of the screen, which is in the patient's right lung. And we froze the tumor and injected immunotherapy into it. And then after a few weeks, we rescan, and here it is, and of course the tumor is gone. And, just took a little freezing. You just freeze a small area and inject immunotherapy into the tumor, and the immune system sees it and attacks it. And this results in this patient was treated in 2015, and the patient's still alive today. It's just a curative response. And we demonstrated this numerous times. I mean, it's not, we're not hiding this or anything. We're trying, we put it out. We have clinical trials. We're trying to get things FDA approved, and we have publications, and so we've been presented in other conferences as well. So you can see that we have a lot of different data on these. Some with some pretty extensive cases. I mean, this one down at the bottom, significant involvement in the liver. We went in, targeted the liver directly, and you can see to the right, we were able to get basically a complete response. This is a patient with prostate cancer, metastatic disease. It might be hard to see, but there's several lesions in the spine, and there's a lesion that's on the left side of the patient, but the right side of the screen, and the rib. And people are like, well, what can you target? Can you target the bone? Yep, sure we can. There's a needle sticking into the patient's rib, and we went into the rib, we froze part of the rib, and then we injected immunotherapy into it. And then, there's his scan 3 months later, completely clear. We treated that one spot in the rib, froze it, injected immunotherapy, everything went away. So this is not an occasional one in 1,000 patients. This is like very common. So this is a different example of one. This is a patient with pretty extensive metastatic disease from breast cancer. You can see all the dark stuff it's on the left side there. It's the right side of the patient. And this patient actually came to me. She was pretty prominent from Beverly Hills, and she went to Cedars-Sinai. They told her there was nothing that they could do. She had 6 weeks to live, and that was it. And somehow she ended up going somewhere else, and somebody who knew me said, hey, you got to call this guy. So she did in 2017 and came and saw me. We treated. What we did was she had a lesion on the sternum. You can see she has on the left side of the screen, the right, that's fluid all in the lung. That lung's completely involved. We froze this area of bone in the sternum. We injected immunotherapy. Now, this is the thing. Remember, they said she had about 6 weeks to live. This is her scan 4 years later. I have some others that are 7 years out now, but she still has cancer, but she's still alive. Now, the thing that happens with some of these patients is that you get an immune response, but it's not complete, but it keeps the cancer under control. I have these patients, they live forever, still with some cancer, but it doesn't go away, but it doesn't kill them. Here's a case of patient. You can see the bright thing on the left side. That's the right side on the screen, but left side of the patient. That's a breast tumor. These are all lymph nodes that are going up by the clavicle. This is what made the patient not a surgical candidate because they can't resect all of these nodes. I think we'll argue in the future, should we ever even operate on these people anyway. This we did, we stuck a needle into a tumor with a, what we call pulse electrical field ablation. Did pulse electrical field ablation, injected immunotherapy. This is, this is her 9-month follow-up PET CT. You can see, you don't see the activity in the breast anymore. You don't see activity in lymph nodes. Patient has had a complete response with basically one treatment of a pulse electrical field with immunotherapy. And so you can see that basically, ablation and immunotherapy, clearly there's lots that can be done. The more and more we understand the immune response, the more we understand how ablation affects the immune system, we can manipulate this to our favor. The other thing is that combinations of drugs, so the more and more drugs that you can use, the better response you're going to get, and that's what you have to inject this in the tumor. You can't give them systemically. The patient's not going to tolerate that, and so and that's it. I appreciate it. Thank you. Thank you very much.